So this was a 73-year-old never smoker who presented with hemoptysis, shortness of breath, was found to have a large mass. Here you can see the CT with a lot of ground glass at one edge. And here you can see this is the tumor, and then here's all this non-neoplastic looking parenchyma. Interestingly, within the tumor, we have all of this micropapillary growth, some of which shows this commonly recognized floret-like pattern. But then here is another pattern that we were recently recognizing with Katsura Emoto as what we're calling a filigree pattern. It's never been officially recognized for lung micropapillary. And then in that non-neoplastic lung, there are all these clusters of tumor cells we call spread through air spaces. And if you look at low power all the way out to the very edge of the tissue, which is about 1.4 centimeters away from the edge here, you see all of these airspace looking tumor cells. I've drawn in green here the border of this tumor. This happened to have a L858R EGFR mutation. And then 1 year later, the patient was found to have metastatic recurrence to bilateral lung, bone, and brain. Here you can see the bilateral lung metastasis 1 year later, the brain metastasis, and then the patient had bone metastasis, and here you can see even later we had these, this sternal metastatic tumor. So for lung adenocarcinoma, we have this subtyping, which was proposed in 2011 with lipidic, acinar, papillary, micropapillary, and solid. And this was accepted by the 2015 WHO. Here you see the different patterns: lipidic, acinar, solid, papillary with true fibrovascular cores, micropapillary lacking fibrovascular cores. This has been shown to have prognostic significance. The solid and micropapillary having the worst prognosis as opposed to the acinar and papillary, and then the more lipidic tumors. So a couple of things happened right about the same time. One of them was this study led by my surgical colleague Prasad Adasamili, where looking at small amounts of micropapillary, it was shown that in patients undergoing limited resection, that these patients had significantly worse prognosis. This is cumulative incidence of recurrence where the survival curves are turned upside down. Sorry if that's a little confusing, but this is a higher rate of recurrence, and this was significant in multivariate analysis. And notice that this got published in the Journal of the National Cancer Institute. He had a training set and a validation set. This is just basic surgical pathology in a very high impact journal. We used to publish in AJSP. Now, because of this classification, we're publishing in JCO and journals like JNCI. So this is an index case that I got as a consult about the same time, and the patient was diagnosed with pneumonia. The consult came with a benign reading, and here you can see there are bilateral infiltrates, a lot of ground glass. In the biopsy that we got, it must have been from the more ground glass area of the tumor, because this is what we saw. And most of what we saw was this pattern that we now call STAS. I didn't know at the time. The contributor had completely missed it. It was a lesion that was easy to overlook. And interestingly, in some areas, you can see that it is actually attached to the underlying alveolar walls, and this will be important as we go through the rest of the talk. So here you can see at low power, these were difficult to spot. Looks like interstitial inflammation, and I think there was a little bit of organizing pneumonia, which was how he had descriptively signed this out. So we call this miliary foci of adenocarcinoma with a micropapillary pattern. So the main points in presenting this, I presented this at the USCAP. We said that adenocarcinoma can present as interstitial lung disease, and that at the time we regarded this pattern of STAS as an important pattern of invasion in lung adenocarcinoma. And the challenge is recognizing that those atypical cells are actually micropapillary adenocarcinoma, and then it's a pattern of invasion. Along about the same time, we encountered this case, and here you can see the edge of the tumor marked in black. It's a similar case. The adenocarcinoma is down here and all this non-neoplastic lung. The thing here is that there's ink on these airspace tumor cells. And like the case I'm presenting today, there are all of these airspace clusters of tumor cells. So it's interesting going back and trying to make some sense out of this. David and the colon cancer people had identified this in lung metastasis to be a prognostic factor long before we even thought about it in the lung. And this was called aerogenous spread with floating cancer cells. And here you can see worse prognosis in patients who had this pattern. And as we look through our cases, most of these have a micropapillary pattern. Some of these have this interesting ring-like arrangement. And then some have these solid airspace nest. And rarely you can see these single cell type of patterns. So we published this a few years ago and showed that looking at in patients with limited resections, patients with any recurrence, distant recurrence, or local regional recurrence, that the presence of STAS was significant, and this was an independent prognostic factor. Then, more recently, we looked at some early stage squamous cell carcinomas, and lo and behold, here you can see the same type of feature. In squamous, you see more of the solid airspace nests. This looks like STAS, and it has similar increased risk of recurrence and lung cancer specific death. And this was published earlier this year by Xiaohao Luo, who was a Chinese physician working with us. So what about frozen section? We did a study and presented an abstract. I keep waiting for the paper. But it's interesting. A few years ago, we looked at micropapillary and our ability to recognize the presence of micropapillary within the tumor on frozen section. And when we saw it, it was quite reliable, but we were not that sensitive in recognizing it. We did an abstract looking for STAS on frozen. And actually, STAS is pretty easy to spot, and we were quite reliable in identifying it. So here's the edge of the tumor in this frozen section. And I hate to say this in the front of the department, but our surgeons are starting to ask about this now at the time of frozen. And fortunately, in the two cases in the last month where I've been asked that, and I said it was there, they were making an intraoperative decision either to do a limited resection versus a lobe. When I said it was there, I was correct. So then there's this controversy, and that is a very healthy discussion to be having whether this is an artifact or not. And here in this study, they did a series of cases looking at samples of what they called, block 1, 2, 3, and 4, and basically showed statistical differences between blocks 1 and 3 in 1 and 4, but not 1 and 2. And their percentage of finding these loose fragments was in 73% of cases, which is about twice the percentage of most of the studies that report STAS. So I think they recognize STAS, didn't call it that, and then there's a lot of other stuff that they're including in their study. The other minor point is that most of the time when we cut the first section of a tumor, we are trying to identify visceral pleural invasion. And I'm not sure they accounted for the fact that about 1/3 of this block number 1 has no parenchymal interface. And this is an important clinical point as we gross these specimens. Much like we do for thyroid, we want to get the capsule. If we're going to evaluate for STAS, we need to have a good interface between the tumor and the adjacent lung. Also, this is in the face of now a growing number of clinical studies showing both in adenocarcinoma and squamous cell carcinoma that this has prognostic significance, not in all studies, but in a number of them is an independent predictor of prognosis, not only in adeno, but in squamous carcinoma. We just submitted abstracts to the USCAP where, much to my surprise, both in small cell and large cell neuroendocrine, this was a prognostic factor. And it's very hard to find prognostic factors in those high-grade tumors which have very aggressive clinical behavior. So as we wrote the original article, it was interesting to go back and look as to what is the biology of this. And interestingly, there's this concept of angiogenesis where back as far as a decade ago, some research investigators have been classifying tumors with preservation of lung parenchyma versus destruction of lung parenchyma. In their category of tumors without stroma formation, they call alveolar or non-angiogenic. And this is described as a pattern called vessel co-option. So one of the questions is, how do these cells survive in the airspace? And interestingly enough, the alveolar pattern in this subset of patients has a worse prognosis. And here's a study which looks like the edge of a tumor, and I think that's pretty good STAS there going into the adjacent lung parenchyma. So here, this is a CD34 stain showing this feature of vessel co-option, and I'm going to come back to that in a minute. And here's another study in the research literature, which those of us who do lung pathology haven't been reading very carefully, but I was speaking with a research investigator about a year ago, and he pointed out that what we were describing with STAS has been very well recognized in metastatic tumors. And here you can see an alveolar pattern, which isn't exactly STAS, but I think it shows this feature that they call vessel co-option, which provides a mechanism for these tumor cells to survive in the lung. So we've been saying that STAS, we think, is true invasion, not an artifact. The STAS clusters appear to be separate from the main tumor. They spread through air spaces and then reattach to distant alveolar walls. It appears to occur in all lung cancer histologies, and that it should be searched for and reported in surgical specimens, particularly those with staple line margins. And if you see it in a staple line margin, you need to tell the surgeon. And my colleagues who regard this as an artifact, I look them square in the eye and say, are you going to confidently tell the surgeon where there's STAS in a margin that the margin is benign? And I told them I don't think that's a good idea. We also don't include this in tumor size or comprehensive histologic subtyping. So enter Yukako Yagi, who I think is in the audience and just came back from Japan, where she gave a beautiful presentation about the three-dimensional assessment of this feature. And the background of this was this concept of recognizing STAS and trying to look at it in a 3D. And so she uses this beautiful 3D histologic technique, which I don't have time to go into, but in this particular case, analyzing areas far from the tumor, sort of in transition area, and then within the tumor, she did this three-dimensional investigation. So these are the results. It showed within the main tumor that the micropapillary structures in the air spaces, those that even in the main tumor look like they're floating in the air spaces, they're all connected. And I'll show you in a minute, there were three-dimensional, sorry, must be an Amber Alert. Some STAS clusters got a little loose, I guess. So anyway, all these are connected. And I have to say, when I saw the movie of these, I was stunned. I mean, I guess I always thought about that, but in fact, it's shown very well in 3D, and we're not used to looking at that because we look at 2D most of the time. And then also the STAS clusters seem to be attached. And that was quite surprising. And then there are these ring-like structures that look like they're balls of tumors surrounding a central space. So unlike the 2D evaluation where the STAS appears to be free-floating, they seem to be actually attached to the alveolar walls. And here you can see they get very close, and then they actually approximate, and they rest up right against the alveolar wall. And I'm going to try this here. So here you can see this STAS cluster, and you see it's right up there and attached to the alveolar wall. This is the way it looks, typically, just like it's floating in the airspace, but in fact, it's attached. And this is one of these balls of tumor cells, and you can see the central space. And so I think that's a way that these tumor cells somehow physically, as they detach from the main tumor, this may facilitate spread into the surrounding lung parenchyma. The other thing that just really blew me away, because I never do CD31 on lung adenocarcinomas, but here's a CD31 we investigated. I thought there would be sprouting of vessels into the STAS clusters, or you would see some breaking of the endothelium in the alveolar walls, but here you're looking in the main tumor. There's not a single blood vessel, and you know, we define it as a papillary cluster lacking a fibrovascular core. So it kind of makes sense that there would be no blood vessels in it. And this concept of vessel co-option, I think, is beautifully illustrated here as you see these clusters. This is Aitkenheron in red, TTF in yellow, and this is again Yukaku staining, CD31 in green, and this is distant away from the tumor, and so I think these STAS clusters have attached and started to grow in a linear fashion along the alveolar wall. So it's completely revolutionized my thinking about how lung adenocarcinoma can spread into the surrounding lung. So in conclusion, our 3D imaging data shows that many STAS cells are not free-floating, but rather attached to alveolar walls, even far away from the main tumor. The micropapillary clusters within the tumor are attached to the alveolar walls. It suggests that STAS clusters may spread within airspaces in a non-contiguous fashion to reattach to distant alveolar walls by this co-option of alveolar wall capillaries to support their growth. This form of spread is analogous to the phenomenon of vascular spread, where tumor cells spread freely within blood vessels to distant sites where they reattach to endothelium and extravasate through the blood vessel walls to form metastasis. And I was trying to make a neural connection here, so I'll just talk about brain metastasis. So when lung cancer metastasizes to the brain, that's how it gets there. But in the lung, it can spread through the airspace through this mechanism of STAS detachment and then reattachment. And then it's possible this ball-like configuration of some STAS clusters can facilitate movement through the alveolar spaces distant from the main tumor. And the frequent alveolar wall attachment of STAS observed on serial 3D imaging disputes this concept that it is an artifact. And I want to thank all of my colleagues, and Yukaku wanted to acknowledge the Warren Alpert Foundation Center for Digital and Computational Pathology here at MSK. Thank you very much.